be sort of blunt about this, I don't think cardiac access is the most useful thing for paramedics. On the other hand, it's everywhere. I mean, people talk about it a lot. And so I think it's useful for you to know what it is, so when people talk about it, you know. And I can't remember if I told this story, stop me if I have already, but I didn't used to teach it. I sort of went back and forth. Sometimes I would teach it, sometimes not. And then one year or a couple of years actually, I put out emails to former students and said, how many of you who were taught access actually use it? How many of you who weren't taught access feel like wish they had known? And there's nothing scientific about that kind of thing, and you get whatever replies you get, and you don't get many. However, they were all certain if they'd been taught it, they never used it, and if they hadn't been taught it, they didn't care. Then a few years ago, a student came to me and said, hey, I wish you did teach access. And I said, why? And he said, well, he was in his clinicals in the ED, and the doctor was quizzing him on his 12-lead knowledge, and he was just, like banging it out of the park till they got to access. And he said, I felt like a dope because I didn't know, I didn't know. So I thought, okay, that's good enough. So the other thing is, it's super easy. So I'm gonna teach it today, and here we go. So we're gonna start with general concepts about it, how to calculate it, and then the significance of learning about it. So first of all, what is the cardiac axis? When we refer to cardiac axis, first of all, we mean the axis of the QRS. There are other axes that really nobody cares about, as far as I know, but cardiologists. You can talk about the axis of the P wave. You can talk about the axis of the T wave. And I've never heard of that, anybody mention that in the emergency department. So when we simply say cardiac axis, we mean the most common one, which is the QRS axis. The QRS axis represents, and we've talked about this before, the major vector, the direction of the main ventricular activation, which is the overall direction of electrical activity. And what we said in fall term, which was a pretty big simplification, is that generally speaking, the main direction of cardiac depolarization goes from upper right to lower left. And that, that's the axis. The main, that when we talk about the axis, it's the main direction of cardiac depolarization. And the reason that's a huge simplification, it's not necessarily wrong, but it can vary quite a bit in individual patients. And so that's what we're talking about, is how do we know by looking at the 12 lead for this individual patient, what is the general direction of electrical depolarization within the heart, meaning ventricular depolarization. Okay? So when we say the axis, that's what we mean. Now, when we talk about cardiac axis, like I said, it's QRS, but it's a very specific part of the QRS, meaning it's all in the frontal plane, okay? So it's all vertical in this direction. So it has everything to do with the limb leads. When we talk about cardiac axis, all we are referring to is the direction of electrical depolarization relative to the vertical plane as determined by the limb leads. It is possible to talk about horizontal axis and look at the V leads, but again, that's not an emergency thing, that's a cardiology thing. So when we say cardiac axis, just to reiterate, I'm just being redundant here, is we mean the main direction of electrical depolarization as determined by the limb leads. Okay, everybody following me? Okay. Now, up to this point, in the fall, I said, oh yeah, there are these numbers, we don't care about them. Okay? We still don't care too much about the numbers. It's probably not worth your while to memorize the numbers, but what we really care about, and you really do need to know, is how the leads are laid out on the circle. Okay? So, for example, AVL, if you want to, you can keep in mind, if you're interested in the number, that contiguous leads tend to be 30 degrees away from each other. So, for example, we know that 2 AVF and 3 are contiguous, and if you look, 30 degrees difference, 30 degrees difference, okay? We know that 1 and AVL are contiguous, and yeah, they're 30 degrees difference. And if you remember at all that system, that Swedish system I showed last week, what they did was they took minus AVR, so it falls into the slot, which is 30 degrees difference from 1 and 30 degrees difference from 2, okay? So knowing how the leads lay out is important. So what I want you to do now, and it's just an exercise, is take your handout, don't look at your laptop, don't look at the next slide, and just do your best to write how the leads lay out along in the circle. So put where you think 1 is, AVL is, 2, 3, AVF. So do that now, take a couple minutes and do it. And again, just an exercise, not a test. Okay, if you're not done, here's the answers. So you can check yourself and correct it, because this, you really should know how those limb leads lay out. Again, I don't care so much about the absolute numbers, but you do need to know the order of how they lay out around the circle. So here, and I printed this off for you in case it's useful, that you can use, sort of keep handy today if it's helpful. Is, again, we've got the layout of the leads, we've got the degrees, and then on top of that, we have the various quadrants, okay? So, and it's not quite quadrants, because you can see the normal area is actually bigger than a quadrant, and the left anterior deviation, that's what LAD is smaller than a quadrant. So what this means is, if the direction in your heart, if the direction of electrical depolarization goes anywhere within that pink, so let's say it can go here, it can go here, it can go here, here, et cetera, et cetera, et cetera. Anything here, that's considered normal. So like I said, when I said it went from upper right to lower left, that was obviously a real simplification, because it could even go in this direction, and it's still considered normal. And then left axis deviation is anywhere in that green area, and then right axis deviation is any place the direction of electrical activity is going any place in the blue, and then we have what's called extreme axis deviation, which is rare, and that's backwards, really, okay? Okay, and that upper right quadrant is really funny, because it's pretty rare for anything to be in the extreme axis deviation. But even though this is the most rare one, it has a whole bunch of names. Everything else, there's only one name for left axis deviation. There's only one name for right axis deviation, or normal. But here are all the names, and they are actually in use for that upper right. So probably the most common is extreme axis deviation. I tend to use extreme right axis deviation because I figure when people are first learning, the more descriptive the better. Northwest territory is really used a lot, as is northwest axis is used a lot, and then occasionally you'll see no man's land. So for something so rare, I think it's quite ironic that it has all those names. Extreme right axis deviation is rare. Most of the time the axis, well, first of all, of course, normal axis is the most common. not necessarily within our patients, but or our cardiac patients anyway, but normal axis is the most common. And I don't know which is more or less common, right axis deviation or left axis, I don't know. Now, there's a whole bunch of ways to determine the axis from a 12 lead, but we're going to use the one that I think is simplest, the most streamlined, and will get us to the point where we know whether it's normal, left axis deviation, right axis deviation, or extreme right axis deviation pretty quick. And we're only going to use 3 leads. Lead 1, lead 2, and AVF, okay? So here's our layout, okay? So first of all, we're going to start with some old news, and you all know this. When a wave of depolarization moves toward the eye of the electrode, the ECG strip shows a positive deflection. When it moves away, it shows a negative deflection. So let's just make sure we're on the same page and say, well, what do we mean by positive or negative QRS? Let's just make sure we're all in agreement here. So when we say positive QRS, it means that the amplitude of the R wave is greater than the amplitude of the S wave. Well, this one is clearly positive because the whole thing is positive. All this is I don't know, maybe there's a little tiny Q wave here, but really all this is an R wave. So I don't think anybody's in any trouble with positive here. This one is also, today, in this class, this is considered positive as well because the R wave is greater than the S wave. And again, here, the R wave is greater than the Q wave. So the majority of the QRS is above the isoelectric. So that one's positive, this one's positive, and that one's positive. Okay? And for our purposes today, there's no difference between the 3. They're all positive. And then negative, of course, is the opposite, which means the amplitude of the S wave is greater than the R wave. And again, you can see here, even though, yeah, there is a bit of an R wave, that S wave is greater, so we consider that negative. Now, we're not really going to talk very much today, except for the next couple slides, about equiphasic QRSs, but I am going to sort of go through it real quick, and then we're going to push them off the table because we don't care. A QRS complex is considered equiphasic when the amplitude of the S and the R are equal. It's, to be honest, it's pretty, if you check this one out, there's probably about a half, but this is the closest one I could find, okay? It's really rare to have a truly equiphasic. And by the way, we measure from the isoelectric line. ST elevation and depression are irrelevant in this. So what does an equiphasic QRS mean? It occurs when the direction of depolarization runs at right angles to the lead. So for example, if you see an equiphasic QRS in lead 1, if you look in lead 1 and you're looking at the QRS complexes and the R wave and the S wave are exactly the same size, what that means is that the direction of depolarization is either straight down or straight up, okay? And for our purposes, because equiphasic QRS complexes are so rare, we're going to forget about them at this point, okay? If you have questions about them later, we can talk about it. So now I want you to look at the handout and go through, let's see, how many is it? I'm not sure. Several pages there. It goes, is it 18? Yeah. So we'll just take a couple minutes and go through and label them as either positive or negative.
Positive.
Okay, and going number 2.
Negative.
Yeah, and you all can just go around. Okay?
Positive.
Okay?
Which one? Negative.
Okay?
Positive.
Okay?
Positive.
Okay? And?
Negative.
Kyle?
Negative.
Okay? 10. That's you, Riley, sorry.
Oh, sorry. Looks negative.
Yep.
Positive.
Uh-huh. Which one? 12?
Positive.
Okay. And then, even though you don't have it, 13. A negative.
Positive.
Okay,
Negative.
okay, okay.
Negative?
Yeah, so this one,
You don't miss.
so we talked about this way back, but when, this is VTAP, okay? And with ventricular rhythms, it's very common for the QRS to simply be one large negative or one large positive deflection, okay? And then the T wave will be in the opposite direction. So if the QRS complex is negative, the T wave will be positive, and vice versa. And so this is exactly what's happening here. One pointed down is either the QRS complex or the T wave. Pointed up is either the QRS complex or T wave. How do you tell the difference? Well, the best way is to say, and it doesn't always work, but most of the time it does, the pointier one is the QRS complex, the rounder one is the T wave. So in this case, so the QRS probably starts somewhere here, and then the J point is here. So it's one big negative deflection, whether you call that a Q wave or a QS wave, it's fine, and then the T wave, okay? So if you're going to be able to tell axis, you know, it's really easy with the sinus rhythms, but if you want to be able to tell axis with the ventricular rhythms, you have to sort of get used to that, okay? And in a way, this is a similar thing where the QRS is going up and then the T wave is flipped. So this is also another ventricular rhythm. Okay, questions about that? Okay. So this is what axis is based on. Okay, so we've got lead 1. And any depolarization that is going out anywhere in the left side, remember it's the patient's left, so this is the left side, this is the right side. So any depolarization that ends up in that left half circle is going to show a positive QRS complex in lead 1. Because even though it's not directly toward it, at least some portion of it is going in that direction. Now, if it's going directly toward lead 1, it's going to show as completely positive. If it's going at an angle but still in that half, it's going to show, yeah, pretty big R, pretty small S. And then the closer it gets to straight up and down, the closer to equiphasic it's going to get. But as long as it's in this half, the R wave will be at least slightly bigger than the S wave. And for our purposes, when we say it's positive today, this is positive, this is positive, this is positive, they're all positive, even though they don't exactly look the same. Make sense? Okay? So any depolarization that is in the right half is going to show up in lead 1 as negative, okay? And again, it'll be, you know, I'm not going to do the same thing, but here would be a really deep S wave and so forth, okay? So, remember we said we use 3 leads, so that's lead 1. Lead 2 is any depolarization that is in this half, okay, is going to show up as positive in lead 2. And any depolarization that is in that half is going to be negative in lead 2. Is everybody following the logic of this? Because if you don't understand this, you're not going to understand axis. Okay? Our third lead that we use is AVF. So anything in that lower half is going to be positive in AVF. And anything in the upper half is going to be negative in AVF. Okay? Okay. So now we're ready to go. How do we calculate axis? It's really simple, okay? Always with this system, start by looking at lead 1. Is it positive or negative? And again, we don't care if it's really positive or only slightly positive. It's just, is it positive? And we know that if lead 1 is positive, then the direction of depolarization, which is the axis, is going to be somewhere in this half. Okay? So if lead 1 is positive, we've narrowed it down. If lead 1 is positive, the axis is either this or that. What's the answer? Yeah, so it's either normal. This means that the axis is either, so it's somewhere in this left half. And the left half consists of normal axis and left axis deviation. Okay, if you don't understand this axis, because there's no point in doing it if you're not following, because we're just going to keep building on this. Okay? So, how do we determine whether it's left axis or normal? Well, if lead 1 is positive, our next step is to look at lead 2. Okay? If lead 2 is positive, so lead 1 is already positive. If lead 2 is positive, then it's going to be somewhere. If lead 2 is positive, then it's going to be in this half, here. If lead 1 is positive, it's going to be here. If lead 2 is positive, it's here. And where's the overlapping part? Which area? Which area? Normal. Okay? So if lead 1 is positive and lead 2 is positive, it's got to be in that area there. So the axis falls into the normal section. Okay? Now, let's go back. If lead 1 is positive, it's in that half. But if lead 2 is negative, it's going to be there. So now, Chris, where's the overlapping area?
I'll be totally honest here, I just want to do an email.
I know, that's why I'm asking you. Let's do it again, okay? If lead 1 is positive, means it's in the right half. And if lead 2 is negative, that means it's going to be there. So where's the area that these two half circles overlap? Excuse me?
The RAD, right?
Nope.
No.
So let's do it again. So if lead 1 is positive, we know the axis has to be somewhere here. Okay, now we're going to overlay the next half circle. If lead 2 is negative, it's going to be here. So one of them is here, and one of them... LAD. Okay, good. Okay. Left axis deviation. So right axis deviation, RAD, left axis deviation, LAD. Yeah, that's exactly right. Okay. Now, at this point, you're done. I said it takes 3 leads, but it only takes, at this point, we're done after 2, okay? So at this point, you don't have to look at AVF. I said we're going to use 3 leads, but we're finished. At this point, you're done. In other words, if lead 1 is positive, the axis is either normal or left axis deviation, and that can be determined by looking at lead 2. In this case, AVF is irrelevant. You're done, okay? So let's put it down another way. Step 1 is always to look at lead 1. And then if it's positive, you've narrowed it down to left axis deviation or normal. Okay? In that case, if you want to determine, well, is it left axis deviation or normal, you go to step 2, which is look at lead 2. If it's positive, it's normal. And if lead 2 is negative, it's left axis deviation. You're done. Okay. I mean, we've got another example, but we're almost done. Okay. So here's, again, a little summary of what we just did. Okay? Now, what if you look at lead 1 and it's negative? Now, we know that the axis must be in the right half of this circle. So, Cody, if lead 1 is negative, We've now narrowed it down. Which two quadrants are possibilities at this point?
Extreme or RAD.
Correct. So this means if lead 1 is negative, the axis has to be right axis deviation or extreme right axis deviation. So how did we distinguish between the two? We look at AVF, okay? So if lead 1 is negative and AVF is positive, our next step was to look at AVF, okay? So where's the area, and where's the area of overlap?
Right axis deviation.
Correct. So if lead 1 is negative, AVF is positive, right axis deviation. Okay? And then finally, if lead 1 is negative and AVF is negative, yeah, now we're in the extreme. Now, note that at this point you're done. In other words, if lead 1 is negative, the axis is either right axis deviation or extreme, which can be determined by lead AVF. So in this case, lead 2 is irrelevant. Okay, so let's summarize. Okay. Okay, so here's our second little box. Okay. And then just to drive this point home, even though the system uses 3 leads, you only need to use 2 for each individual 12 lead. You only need to use 2. You either use 1 and 2, leads 1 and 2, or leads 1 and AVF. So if lead 1 is positive, the axis is either normal or left axis deviation, and AVF is irrelevant. If it's negative, then lead 2 is irrelevant. Okay? Okay. So why do we care? My argument is we don't care that much, but we care a little bit. There are a couple times where it's useful. So normal, we don't need to talk about that. What are some causes of left axis deviation? Well, number 1, it could be a normal variation. Okay. Number 2 is mechanical shift, pregnancy, obesity, ascites, emphysema, etc. What happens, if you think about it, if a person becomes pregnant, the heart actually starts shifting up and to the left, and the way that shows out on the 12 lead is as left axis deviation. So there are some mechanical things that happen that can shift the heart to the left. Okay? Left ventricular hypertrophy. What is left ventricular hypertrophy? Even if you know exactly, but from the terms, what does it mean? Yeah, so the left ventricle grows, there's more tissue mass, and if there's more tissue mass on the left side, what that means, there's more electrical activity on the left side, and this will shift the whole axis towards the left. Left bundle branch block, we want to talk about that now. Hyperkalemia causes everything, so it truly does. It's going to be on all the other lists, so it might as well cause left axis deviation. Ventricular rhythms, do you remember when we saw the one, I said, oh, this is a ventricular rhythm. So sometimes ventricular rhythms will have a left axis deviation. Because remember, where is the ectopic focus in a ventricular rhythm? In the ventricles. In what part of the ventricles? Trick question. Anywhere. So it could be up toward the top, could be down toward the bottom, and so where the ectopic focus is going to really influence the axis. So it could be left axis deviation. Inferior wall STEMIs will sometimes cause left axis deviation, WPW, and then it could be just a congenital defect. So what causes right axis deviation? Well, again, normal variation, mechanical shift, which sounds a little bit odd. But one thing that can happen is, in particular, another mechanical shift is if somebody is very, 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 very thin, the heart will tend to drop a little bit, and that will cause right axis deviation. Right ventricular hypertrophy, right bundle branch block, hyperkalemia. Here we go again. Could cause anything. Left axis deviation, right axis would be WPW. Ventricular rhythms. Again, it depends on where the ectopic focus is. Lateral wall MI can cause right axis deviation because this part of the heart is dying, and that shifts the electrical activity over to the right. The one really useful thing for right axis deviation, there actually is one, I think, acutely useful thing. Sodium channel blockers, that should be overdoses, or toxicity. And one that we sometimes bump into in the field is TCA, tricyclic antidepressant. Has some very specific ECG characteristics that we're going to talk about in spring term, and one of them is right axis deviation. Some causes of extreme right axis deviation: hyperkalemia and ventricular rhythm. So notice that hyper-K and ventricular rhythms can cause left axis deviation, right axis deviation, and extreme right axis deviation. In actuality, the most common cause of extreme right axis deviation is left and right arm, left leg reversals. Okay, so if the leads get mixed up these days, though, you don't need. It used to be that it was useful to have extreme right axis for that reason. These days, the modern awareness tell you, they suspect lead reversal. Okay, so now you can pick out your next handout. You can take, we'll take about 10 minutes and do it. I'm going to do number 1 together so I show you how we're going to go about it. So Koa, if we look at lead 1, positive or negative in this one?
Positive.
Okay, and lead 2?
Negative.
Okay. Now, AVF, is it worth looking at? Say it again. No, it's irrelevant. Remember, we only need 2. You just don't know exactly which 2 it is until you know if lead 1 is positive. So I don't want you to, if it's not relevant, I don't want you to put it down because I want you to learn, to do it. And then what's the axis? Who knows? Yep. Okay, so let's take, okay, so the rest of them you can do.
Yeah, nice stuff.
We'll do them together. Okay, so Andrew, number 3, please.
Okay, lead 1, negative.
Okay,
So then we look at AVF, positive. So it's right axis deviation.
okay. Questions? Okay, Cody, number 4, please.
1 is positive, so then I go straight to 2. 2 is negative, so the axis is left, or LED.
Good. Okay. Okay, Chris, number 5, please.
1 and 2 are positive, so there's null.
Okay. Okay, and number 6, please.
6, 1 is negative, and AVF positive is normal.
Is what?
Normal?
Not if lead 1 is negative.
Right axis.
Yeah, there you go. Okay. That, by the way, and it's a 12 lead we'll look at later, but that's a TCA overdose right there. Okay. Okay, Kyle.
Lead 1 and lead 2 are positive. So
Okay.
that's normal. Lead 1 looks negative.
Okay.
And then AVF is positive. So right axis deviation.
Good. Okay, go on.
When I said negative,
Good.
AVF said positive,
Uh-huh.
RAD.
Gotcha. Good. Okay, Grace.
Pretend we said is lead 1 is negative, and then AVF is also negative, so it's going to be extreme.
Yeah. And remember, one of the reasons for extreme right axis deviation was a ventricular rhythm. Okay, so that's what's happening here is VTAC.
1 and 2 are positive, so that's normal.
Okay. Oh, wait, 1 and 2
I mean, 1 and, yeah.
lead
Oh,
2?
no. It's 2 negative.
Yeah.
Yeah, so then it's LED.
And that's hyperkalemia. Okay, so it's the end of kind of the formal part. I am going to say one more thing, and I specifically put this at the very end. What you will be expected to know on the midterm exam and the final exam is what we just did, is, well, just what was in the lecture, okay? But I'm going to make an argument here for when you're in the field, okay? Not on a test, but when you're in the field, I think you can stop with lead 1 and lead 2. And here's my argument, and never worry about AVF. Here's my argument for that. If lead 1 is positive, you know it's left axis deviation or normal. And that you need to tell the difference between. And that's easy. So you look at lead 2 and you go through that. But if lead 2 is negative, that means it's either right axis deviation or extreme right axis deviation. So I don't think you need to go further than that. And the reason is because, and again, this is just field, is because extreme right axis deviation is pretty rare. So the chances are, if you do get to this point and lead 1 is negative, it almost certainly is right axis deviation, not extreme right axis deviation. The second reason is it doesn't really matter that much. There's nothing that I can think of that you would say, oh, right axis deviation. Well, let me see if it's extreme right axis deviation so I can rule this thing out. It doesn't work like that. So just if you're going to keep axis in your repertoire when you're on scene, this is one way to sort of streamline it a little bit, is just look at lead 1 and lead 2. Okay, so for this week, you've got 2 pieces of homework and practice, and I've printed out both of them. So if you want to pick up a copy so you don't have to print them out yourself, there they are. And otherwise, we're done.